recording button. Great. Yes.
All right, thank you very much for having me, Tina. So indeed, my name is Michael Bui, and I'm a second-year PhD candidate at the Health Technology and Services Research section at the University of Twente. My current work area is health preference research, which is a sub-area of health economics. And here we aim to optimize the value of decisions made in healthcare by eliciting values and preferences of relevant stakeholders and incorporating this evidence into clinical decision-making. The types of methods we use include choice experiments or multiple criteria decision analysis. And today I'll be presenting an example of this. Specifically, I'll be presenting our findings on surgeons' risk perceptions and treatment decisions in palliative care for frail geriatric hip fracture patients, a structured expert judgment, and conjoint analysis. So the findings that I present here are based on the research I conducted during my master's thesis, focusing on whether frail patients should or should not undergo surgery after incurring a hip fracture. And to introduce the decision problem to you, I'll first start with the clinical context and then describe the methods that were used. So due to the aging population, epidemiological projections suggest that 6.26 million individuals will incur a hip fracture annually by the year 2050. And in worldwide practice, surgery is considered to be superior over non-operative treatment in terms of functional recovery. But for patients with a limited life expectancy, the focus may no longer be on functional recovery, but rather on the palliative care. And in this context, prospective cohort studies have shown that choosing non-operative treatment does not necessarily yield an inferior quality of life as compared to operative treatment. However, clinical guidelines to support the decision to abstain from surgery are currently lacking. The primary advice given is that surgical overtreatment should be prevented. And this is the case when severe post-operative complications are suspected or when patients are at a high risk of early mortality. While clinicians do make such assessments, the explicit factors driving these decisions are not known. And this is why we want to systematically capture the expertise of surgeons in palliative decision-making to inform guidelines where possible. And we did this by presenting hypothetical patient cases to surgeons and asking them to recommend either operative or non-operative treatment to learn from their decisions. Well, the first step to design such patient cases is actually to identify patient characteristics which are clinically relevant to the decision problem. And since palliative non-operative management is primarily reserved for patients with a limited life expectancy, we identified these characteristics through a systematic review and meta-analysis of preoperative predictors for early mortality following hip fracture surgery. We ended up narratively analyzing 100 studies and quantitatively synthesizing 33 studies. The quality of pooled evidence was appraised using the grading of recommendations, assessments, development, and evaluation framework, which is more commonly known as the GRADE framework. Well, through the systematic review, we ended up identifying 10 promising clinical characteristics that we could include. These were, in this case, age, sex, fracture type, physical status, presence of metastatic carcinoma, end-stage renal failure, preoperative residence, functional status, and dementia. And we used these 10 different attributes to describe different patient cases. And the attribute levels describe the value of each attribute that it can actually take. These variations enable us to construct a wide range of hypothetical patient cases, in fact, 1,536 different combinations. But you can imagine that it is very impractical to let surgeons assess over 1,000 patient cases in a survey, so we'll need a more proper and clever strategy involving experimental design theory. So what is the goal of constructing experimental design? Essentially, it is about constructing a set of patient profiles which allows for estimation of precise parameter estimates for influence of attribute levels by balancing two aspects, which are known as response efficiency and statistical efficiency. So when we consider response efficiency, we want to minimize measurement error, for instance, due to response fatigue. Practically, that means that you should not include too many questions in your survey. Secondly, we have a more methodological component, statistical efficiency, in which we want to minimize confounding between the effects of attribute levels and present sufficient patient profiles to estimate effects precisely. So there's a trade-off between minimizing response burden, but at the same time asking sufficient questions to gather enough statistical information from these decisions. So what are now the steps that we took in constructing our experimental design? Well, we first start off with generating the full factorial design that is considering all possible combinations of attribute levels, so all 1,536 different patient cases. Then we have to examine whether there are potential implausible combinations of attribute levels. Implausible meaning they may not occur in real life or in clinical practice. This was the case in our attribute selection because we had an ASA score, which is a subjective scoring system for the overall well-being of the patient, and some comorbidities such as metastatic carcinoma. And what is not really possible in clinical practice is to have an ASA score of 3, which is systemic severe disease without constant threat to life, and having metastatic carcinoma where you are at a threat of a constant threat to life. So any implausible combination, in this case ASA3 and metastatic carcinoma, were removed from the full factorial design, which left us with 1,132 profiles, which is of course still too many to present to a surgeon. So then we had to think about what effects do we actually want to estimate. In this experiment, we decided to only focus on main effects. And what we then did was we selected 16 patient profiles from these 1,132 candidates based on something called the D-efficiency. Well, in short, a D-efficient design aims to minimize the determinant of the inverse of the information matrix, or equivalently maximize the determinant of the information matrix. And what this essentially means is you try to shrink the confidence interval by choosing a design matrix X for a given number of experimental runs that you want to include in your survey, such that the information matrix is non-singular with minimal collinearity, because then the effects that you estimate for each of the attribute levels can be estimated independently of each other. You have fewer correlations between them, and as a result, lower standard errors in your design. So what is an example of potential choice task that we have? I have one shown over here. So as you can see, we have a patient case comprising the 10 attributes set at different levels. And we ask surgeons the following question: which treatment would you recommend to this patient? Where we give two options, either operative treatment or non-operative treatment. We ask this question for all 16 patient cases. And with that, we end our choice experiment essentially. Well, the choice data were analyzed using a hierarchical Bayesian logit model. Given that our research was conducted as part of a master's thesis, we did not expect to obtain a very large sample size. So rather than relying on frequency statistics, which require asymptotic theory, we opted for a Bayesian analysis framework instead. We modeled the treatment choices. Basically just using the logit over here. We assumed that we had prior knowledge based on our meta-analysis. The assumption we made was, in line with Dutch clinical guidelines, we assumed that the risk factors prognostic value for early post-operative death could function as a proxy for surgeons' inclination to abstain from surgery. That is the only guidance currently given in the Dutch clinical guidelines. So we thought it was a fair assumption to make that the effect sizes for mortality could also be seen as an effect size for abstaining from surgery. As there's always a subjective component involved in Bayesian analyses, we made sure to plan the analyses and report it according to the WAMPS checklist, which stands for when to worry and how to avoid the misuse of Bayesian statistics to ensure transparency and reproducibility of the analysis. But of course, considering that we had a small sample size, we also thought it was relevant to in advance have an a priori power analysis. And since we already had this prior knowledge for a Bayesian model, we could also use those prior beliefs as effect sizes in a Monte Carlo simulation to simulate responses based on the expected effect size of the different coefficients. So what we did was we constructed a Bernoulli process where the probability parameter was parametrized by the inverse logic lint function. And for each of the beta coefficients, we filled in the betas that we believed to be true based on the meta-analysis that we performed. Based on this power analysis, we expected to at least detect meaningful effects for end-stage renal failure, metastatic carcinomas, and heart failures, which are the 3 black lines at the top, because they require relatively small sample sizes to detect an effect that is non-overlapping with the null effect. Given small sample sizes. But of course, this is part of the structured expert judgment series, and we also performed a structured expert judgment. And for what reason? Well, we wanted to study what the risk perceptions of surgeons were and what their capabilities are to prognosticate mortality risk, since this perceived mortality risk may influence treatment decision-making. For this purpose, we used Cook's classical model with and without performance-based weights. In total, we used 12 calibration questions about 30-day mortality prevalence, for which we used retrospective data from the Dutch Hip Fracture Audit Task Force Indicators Group, which described a total of 7,506 patients. To make the calibration questions relevant to our target questions, so relevant to the patient cases that we describe, we age-matched the patients in the cohort to those in the hypothetical patient cases to base the z-values on. And we also focused on patient characteristics that were selected as attributes in our patient cases. So an example of such a calibration question in our case was, what percentage of hip fracture patients aged 85 years or older with an ASA-4 classification died within 30 days after surgery between 2017 and 2019, according to the Dutch Hip Fracture Audit Group? Well, the target question was, according to you, what is the probability that a patient with these characteristics would die within 30 days after surgery? And this question would be posed for each of these patient cases alongside with the treatment decision question. Well, we are aware that there is a mismatch between the format of the calibration question, which focuses on continuous variables, and the target question, which focuses on discrete variables. But this consideration was made because if we were to use calibration questions based on discrete random variables, we would need a larger number of calibration questions to satisfy this assumption of following this asymptotically following the chi-square distribution. And since we also had these treatment decision questions in there already, we were afraid that it would lead to a very high response burden. So we now mixed up calibration questions using the continuous random variables because it was easier to satisfy the assumption of the asymptotic assumption for a smaller number of calibration questions. But then we still treated the target question according to what it is, a probability for a discrete event. Then on to the results. Well, first starting off with our choice experiment. We ended up with a sample of 14 surgeons responding to our survey. And we found that patients with metastatic carcinomas, severe heart failure, end-stage renal failure, and dementia had a higher odds of receiving a non-operative treatment recommendation. We also reassessed our regression results with non-informative priors and found that the choice of priors did not affect whether the credible intervals were non-overlapping with the null effect. So in that regard, our results appear to be robust regardless of prior choice. But some of the findings we had were actually unexpected given our a priori hypotheses, because in our power analysis, we did not actually expect to find a meaningful effect for dementia. And I'll come back to this observation later on in the discussion. Then on to the structured expert judgment, first starting off with the calibration question. Each block essentially represents one calibration questions, and all dots accompanied by the horizontal bars correspond to a response of a single surgeon to the calibration question. In particular, their best estimate, denoted by the circle, and the 90% credible intervals. And the surgeons indicated in blue indicate surgeons with calibration scores above 0.05. So overall, we only found 2 surgeons which were well calibrated according to this cutoff value, so to say. And what we also observed was for the calibration question involving the most frail patient group, calibration question number 10, that the risk was underestimated by quite a lot of surgeons, even though this was the most frail group. This was quite a striking finding to us. Then we also put the 2 results together, so the treatment choices made and the risk perceptions of the surgeons. And what we generally observe, well, let's first introduce the figure. On the left hand of the figure, you see the treatment choice proportions for all of the patient cases, and on the right hand, you see the distribution of the estimated mortality risks, as well as the pooled estimates. The performance-weighted estimates are indicated with crosses, and the equal weights estimates are shown in circles. And from these figures, we can find several observations. Well, first, we see that the preference for non-operative management increased with the perceived mortality risk on average, which is what one would expect based on the current clinical guidelines. We also see that surgeons with higher calibration scores in general estimated a lower mortality risk than the average surgeon. But what is more striking, I would say, is that there is a substantial variation in the mortality risk perception. Because if we look at these box plots, these whiskers can range from 10% to 95% mortality risk for a single patient case. And this is quite substantial because depending upon the surgeon you may end up with, you may receive a very different prognosis. In general, we see quite a lot of heterogeneity within the respondent sample at the individual level. So we found that the intraclass correlation coefficient was 29.9%, which means that 29.9% of the explained variance in the made choices can be attributed to personal differences between surgeons and not necessarily to variations in the attribute levels. But we also see that there's a different sensitivity of risk perceptions to changes in attribute levels. So I've highlighted two surgeons as an example over here. Across all 16 patient cases, one surgeon estimated mortality risk between only 5 and 35%, and another surgeon estimated risk between 15 and 95%. So that's quite a different range and bandwidth for the mortality risk perceptions. But what was also interesting to see was surgeons who were more inclined to recommend non-operative treatment frequently did not necessarily have higher risk perceptions. So for instance, in the first surgeon highlighted in yellow, non-operative treatment was recommended in 11 out of 16 cases, even though the mortality risk perceptions were quite low, only between 5 and 35%, whereas for the other surgeon highlighted in yellow, the risk perceptions were more variable, reaching up to 95% even, yet only 4 recommendations for non-operative treatment were given. Well, then on to our discussion. As I mentioned before, we were somewhat surprised, based on our power analysis, to see the influence of dementia on surgeons' decisions to abstain from surgery. In our prior beliefs, we assumed that a risk factor's prognostic value for early death could function as a proxy for the likelihood of receiving non-operative treatment. Dementia itself had a low to moderate prognostic value for post-operative mortality risk, but what is not captured in our prior beliefs are implications for quality of life. Patients with dementia may enter heavily debilitated states following surgery, for instance, due to delirium. And we think that the perceived benefit of non-operative management is derived from perceptions of poor quality of life prospects, in addition to mortality risks. Then what we also observed was that surgeons' collective judgments for the frailest patients may potentially be downward biased. So what did we do? On the upper right 2 columns, I have the pooled estimates using equal weights and performance-based weights from the structured expert judgments. And in the first 4 columns, I have mortality prediction models based on the data-driven input, let's say. So logistic regression models, for instance, which predict mortality risk for patients within 30 days based on certain characteristics, because we wanted to see how the expert judgments would compare to the prediction models that are already published in literature. Well, the first thing we observe is that quite a lot of the risk factors included in the prediction models also overlapped with the attributes considered in our study. But in addition to that, we also identified several stronger risk factors based on our meta-analysis, such as severe heart failure, end-stage renal failure, and presence of metastatic carcinoma, which are not always included in these mortality prediction models. Yet, even though we include risk factors which are associated with a higher prognostic value for death than included in prediction models, the expert estimates tend to be lower than what is predicted as a maximum value in the objective models. For instance, in the alveolar hip fracture score or alveolar hip fracture score 90, AHFS in short, they have maximum predicted risk of 68.4% and 64.5%, whereas the expert estimates do not exceed 62.9% for the most frail patient case, even though you would argue that these patients are in a more severe health state based on the evidence we found in our meta-analysis. What we think is that mortality prediction models could help streamline risk perceptions among surgeons, as we've seen a lot of variation in the risk perceptions across surgeons, but also in the collective judgments, we see that there may be a potential downward bias for the most frail patients. And although previously I did argue that if surgeons are more inclined to recommend non-operative treatment, that may not necessarily be associated with higher mortality risks, we still think that in the shared decision-making context, it is important to inform patients objectively on what their prognosis is, so that they can collectively come to the most suitable treatment option. So based on what we observed, we think that objective mortality prediction models could aid in this context to aid shared decision-making. This was essentially what I had prepared for the presentation, and if you have any questions, I'll be very happy to address them.
Great.